Again, I apologies for being late this morning. Over the course of this presentation, what I'm going to be talking about is menopause, common menopausal symptoms, and how it might be a little bit more difficult to navigate that sometimes following a cancer diagnosis. And please ask me lots of questions at the end if you have any questions. I'm just going to try and get myself familiar with this first now. So, yeah, perfect, okay. So look, I'm going to start with some really basic terminology at the start just to get things moving. And I'm sure you probably all know this, and I might be covering kind of really basic stuff that you know. But the menopause essentially means that periods end, okay? And that's usually due to loss of ovarian follicle production within the ovary. And that's what natural menopause is. There's a natural decline in the amount of follicles and eggs that women have in their ovaries, which reduce over time, and that culminates in the last period when the ovary no longer releases an egg from the ovary. And we don't have an adequate biological marker to show the exact moment that someone becomes menopausal during natural menopause. So it's looked at retrospectively, and we can only define someone as being menopausal when they're 12 months or 1 year after their last period. Induced menopause, then, there's probably people in this room who've had an induced menopause, which has been brought on by something else. And that can either be surgical removal of the ovaries, which would be an instant menopause, or due to chemotherapy, which can be toxic towards the follicles in the ovaries, and that will often induce either a temporary menopause or a permanent menopause, and also due to other medications such as GnRH analogues, which some people might have to take for their post-cancer treatment. And then you've got an early menopause then, when someone has a menopause between the age of 40 and 45 years, and a premature ovarian insufficiency, which would be menopause under the age of 40. And both those conditions can sometimes be associated with risk factors compared to peers of your own age group, and we'll discuss that in due course of the presentation. So let's start. I'm going to start with two basic concepts. Everybody in the room will have an individual perimenopause or menopause, and there's huge individual variability, and that is the same whether you've had a cancer diagnosis or whether you've not had a cancer diagnosis. So it's not going to be the same for everybody. It's going to be different. But the same principles apply. So the concept of menopause, or helping people through menopause, we want to improve and resolve symptoms of menopause if we can, if they're troublesome. We want to optimize people's long-term health, because the menopause can induce changes within the body which can increase risk factors for conditions such as heart disease, diabetes, and bone loss, which can accelerate the onset of osteoporosis and heart disease in some women. So why does it happen? There's no universal agreed consensus in this. We don't know why it happens, other than obviously an induced menopause, which we know why that happens, because that's due to either surgery or medication. But natural menopause, we still don't know why it happens, and there's several theories. So the first is the aging theory, whereby some people think that we were designed to have menopause at a certain age, but we're now living longer than that. But that doesn't explain why men, although they have some degree of an andropause, they can still potentially produce sperm, which can help with reproduction, but women have a menopause and then they can't. So we can't explain for that dichotomy between men and women at the moment. There's also the behavioural theory, which is interesting, whereby some people put forward the theory that in the past men preferred to mate or have sex with younger women, and that accumulated genetic differences in older women, which transferred to other generations down through the years, which culminated in menopause. Or the kind of more popular theory now is the grandmother hypothesis, whereby it's thought that there was a longevity advantage given to women to stop having periods at a certain age so that they could help with the rearing of their grandchildren, and that gave them some sort of advantage or longevity over time. So that's kind of one of the more common theories we have at the moment, is the grandmother hypothesis, which is still controversial. So menopause after cancer, and why it might be a little bit different. So in the first instance, people in this room will probably have natural menopause. They might have had a cancer diagnosis when they were younger. They went through their treatment. They still went on to have periods, and now they're going through natural menopause or have went through natural menopause, similar to other people. The other factor we need to take into consideration that people in the room might have had an induced menopause due to a surgical menopause, chemo, GnRH analogues, which is sudden. And that can be really grueling for people because the body hasn't had a chance to adjust to some of the hormonal changes that can occur in perimenopause. And it happens really suddenly, and that can sometimes be associated with more severe symptoms in some women. Menopause, you can get menopause-like side effects due to adjuvant treatments that some people will have for breast cancer and other hormone-sensitive cancers. And then they can be associated with some really kind of difficult symptoms for some women due to the fact that they reduce estrogen via different mechanisms. And we'll discuss that in due course as well. And the other thing is that some people in the room might have had an early menopause or premature ovarian insufficiency due to having had cancer at a younger age. And why is it important? Why are we talking about menopause? So the first thing is symptoms. So 75 to 80% of women will experience symptoms of menopause. And that will affect them in different ways. And sometimes, like I said in the last slide, it can be more severe in women that might have had cancer. The other thing is that it can have long-term health implications which can impact on quality of life, and we'll discuss that. And then on average now, because we're living longer, a third of women will be in menopausal stage for about a third of their life, if not longer. We want to optimize that time, and we want to make it as healthy as possible and that people can thrive in that time as well. So in terms of the short-term effects of menopause, this is all symptoms. Symptoms, symptoms, symptoms. Not everybody will get symptoms, but 75 to 80% of women will experience at least one symptom. They last on average 3 to 7 years, but a third of women will experience symptoms lasting longer than that. And it is recognised that about 10% of women will experience symptoms into their 60s, if not longer. 25% of people will experience a difficult menopause or menopause transition with multiple symptoms affecting their life and quality of life. And that is 1 in 4 women. The long-term effects then, it can increase the risk of cardiovascular disease due to changes that can occur in the body, which I'll discuss in further slides. And that's of relevance because cardiovascular disease is a leading cause of death in women. So one in every 3 women will die of a cardiovascular-related cause, which is the leading cause of death. It can increase the risk of osteoporosis because during menopause, we will lose at least 2% of our bone mineral density on an annual basis for a good few years during the process until it levels out approximately about 7 years later, but that will vary from person to person. So menopause is a risk factor for the development of osteoporosis. Up to 80% of women will experience a symptom of genitourinary syndrome of the menopause, which are the vaginal and bladder symptoms associated with menopause, which we'll discuss in further slides. It can be an increased risk of dementia in some genetically predisposed people, so it's important to say that every woman will go through menopause, but the majority of women won't get dementia. But it does seem to be a vulnerable time for some people that might have a genetic predisposition to dementia, and that is linked to the ApoE4 gene. And it's an independent risk factor for frailty in that it causes changes within our skeletal and bone system, which can increase the risk of falls and increase frailty in general, which is a marker of health, long-term health. But it's not always negative, and there's a lot of, as Fiona said earlier, there's a huge spotlight on menopause at the moment, and it's not always, a lot of it is negative. But for some people, they actually can find that it's a positive thing. It's a natural, or it's a reproductive milestone. Every woman will go through it. Some people find it a time to introduce changes in their life. They find it a time of opportunity. And lots of people love not having any periods or having to worry about periods, especially if they've had painful and heavy periods in the past. So that can be liberating for some people, not having to worry about that and not having to worry about contraception as well. And there can be cultural differences. Typically in the Western world, we kind of tend to look at it as negatively, whereas in the Eastern world, in China, women are more are acknowledged for their wisdom, and menopausal women have a different status within society. But it can be sometimes difficult to take this viewpoint if you're having a difficult menopause, and we have to acknowledge that as well. So a little bit about the perimenopause and the menopause transition, and possibly not everyone in the room might have had a perimenopause if they've had an induced menopause and a sudden menopause. But essentially what perimenopause is the stage prior to menopause, which varies from person to person when the hormonal environment starts to change. And that can start, on average, probably 5 to 7 years before menopause. Typically, with the average age of menopause being 51, it might start when someone is in their about 45, but it can start earlier than that. And subtle changes can start when someone reaches their late 30s. And how someone response to those changes is hugely variable. For some people, they just notice a little bit of a change in their menstrual cycle, but for others, they're really affected by the oscillation or the altered hormonal environment, which can progress and accelerate through perimenopause until the moment they become menopausal. And how that manifests then is in the erratic hormone production as the ovary starts to change, and we can get menstrual changes like I've discussed. With the hormonal fluctuations, people can get typical perimenopausal symptoms, which can sometimes be different to menopausal symptoms, which are caused by loss of estrogen. So fluctuating hormonal symptoms can be irritability, mood symptoms, feeling on edge, anger, or headaches, palpitations. So it kind of when you think of this kind of oscillating movement up and down, which can be irritating to look at, what I tell people perimenopause is irritating. It's irritating mood symptoms, irritating to your brain, and irritating to your heart, and those are the symptoms that you can experience during oscillating hormonal production. And then when hormone production starts to, with the drop in estrogen and progesterone production then towards advanced perimenopause, when you're approaching menopause and after menopause, you get your typical menopausal symptoms, which would be your hot flushes and night sweats, vaginal symptoms, and other type of mood symptoms and joint symptoms. That's a very simplistic way of explaining it, and there's multiple symptoms that people can experience, but they can be the more common symptoms. So I'm not going to go through every symptom because there's well over 40 symptoms, but I'm just going to go through the more common symptoms that people can experience. So like I was saying, mood symptoms, people go on about hot flushes and night sweats, and they can be really debilitating, there's no doubt about that. But from what I encounter in clinical practice, it's the psychological symptoms, the mood symptoms I find that people struggle with the most. And that would be anxiety, irritability, mood swings, feeling overwhelmed, tearfulness, low mood, worsening PMS in the perimenopause, which would be a hallmark feature of that, and loss of confidence, which can be multifactorial. And that's due to the altered hormonal environment interacting with neurotransmitters in the brain to give those symptoms. Vasomotor symptoms then are your hot flushes and night sweats, and that's due to the thermoregulatory system in the brain, which sits in the hypothalamus, and that regulates body temperature. That starts to change due to the change in the hormonal environment, so people have to work harder to maintain an ambient body temperature. And because they're working harder, they can sweat to kind of maintain their ambient body temperature, or sometimes people actually feel cold. And that's due to that changing hormonal environment as well. Cognitive symptoms are really common, so brain fog, problems with word finding, lack of focus, poor concentration. That can start at the early perimenopausal stage for some people, and actually can take a while in the menopausal stage for the brain to adapt to that. We do think that the brain responds to these changes in time, and people actually, the brain fog improves, but it can be quite troublesome for a lot of people, and especially when they're not used to having some of these symptoms, and it can impact on their function and quality of life. Then you've got your miscellaneous symptoms like your headaches, migraines, tinnitus, dizziness, vertigo, poor sleep. All of these are multifactorial and can be caused by other conditions, but some people do report an increase in these type of symptoms as well during perimenopause and menopause. The cardiovascular system then, like I was saying, when you go through menopause, the risk of cardiovascular disease increases, and that's due to little changes that occur over time as we lose our estrogen. And that's thought to occur due to changes within our metabolic metabolic factors in the body, such as our cholesterol, with an increase in the LDL, which would be the bad cholesterol, and a reduction in HDL, the good cholesterol, and a change there's an increased insulin resistance, which can predispose to an increased risk of diabetes. The weight distribution can change, so people there can be weight deposition around the abdomen, which can lead to increased risk of diabetes, and there can be the changes in the blood vessels in the body over time. They can become a little bit stiffer, leading to increase in blood pressure. So, and there can be an increased risk of deposition of plaque within the arteries. That all occurs really, really slowly over a period of time. But all those changes occurring at a minute level work to increase the risk of cardiovascular disease for some women, not every woman. Muscles and bones. So people report feeling generalized aches and pains because estrogen can act as a lubricant within our joints. Estrogen is also really important for muscle, so people can lose muscle mass during menopause, and it also can reduce bone mineral density, which then can accelerate the onset of osteoporosis for some women. So therefore, we need to work hard during perimenopause and menopause to improve and help to manage some of those changes that are happening in our muscle and bones by making sure that we're optimizing the other factors that are involved in bone health in particular. So having our vitamin D during the winter period, making sure you have a normal and satisfactory vitamin D level, making sure you're getting adequate calcium in your diet, and I know that Samantha will be probably talking about that in her talk, and making sure we're getting enough weight-bearing exercise, which is really important. I'll be discussing that in a future slide. A little bit about menstrual effects in perimenopause. The menstrual cycle will change, so some people report lighter and shorter period cycles. Other people, their periods become heavier. So during the perimenopause, it's not uncommon to have to actually seek support from gynecological services, especially if you're having heavy periods which are impacting on your quality of life, and it might be a time where you might have to have a Mirena coil or an endometrial ablation or other types of gynecological interventions. Genitourinary symptoms are extremely common, and so GSM, genitourinary syndrome of the menopause, it's estimated, depending on the study, that up to 50 to 80% of women will experience at least one of these symptoms. And this is not reversible, and what I probably should have said when I was talking about symptoms is that the majority of menopausal symptoms will resolve with time, which is a really positive thing. But GSM, if those symptoms are present, they won't go away with time, so they will need some form of treatment. So symptoms that some people can experience due to loss of estrogen around the bladder and the vaginal area can include overactive bladder, recurrent urinary tract infections, vaginal dryness, vaginal itch, vaginal discharge, painful sex, loss of libido, and that can be multifactorial. It's not just down to GSM or genitourinary symptoms, but can be due to other factors as well. And this is formally known as genitourinary syndrome of the menopause. And then you've got some other symptoms that I'm not going to go in for the purpose of time, but GI symptoms can be common, skin, hair, mucous membranes, and breast symptoms can be also common as well during the perimenopause. So when you are experiencing menopausal symptoms and you want to bring it up with your doctor, I know that you've got a menopause symptom checker in the brochure today, which would be really helpful. And there's a load of these on the internet, but it's really useful to have a look at these symptom trackers before you go in to see your doctor, because it can really focus your mind, and sometimes you mightn't be aware of some of the symptoms that might be associated with menopause. And coming in with that can help to kind of focus a consultation as well. So when we are looking and addressing a menopausal consult, it's not just symptoms that we're trying to help people with. We're taking an overall look at your health and trying to optimize your long-term health risk factors as well. So symptoms are obviously important and incredibly important, and that will be discussed. We're going to be looking at your individual cardiovascular risk factors to see if they can be improved, and that can be different for everybody, such as family history, cholesterol, presence of diabetes or pre-diabetes. If you've had previous radiotherapy on the right-hand side of your chest, all those things can increase the risk of cardiovascular disease. Bone health risk factors are really important. We're going to be discussing your diet. We're going to be discussing ways of increasing weight-bearing exercise if possible. We're going to be seeing, are you engaged in screening? Because screening is important. It's ways of helping to, I suppose, pick up other forms of cancer that can be picked up at an early stage, potentially, such as bowel cancer, cervical cancer, and breast cancer. We'll be discussing your periods during the perimenopause phase. Are they impacting on your quality of life? Do we need to do something about that? We're going to be discussing contraception, because unfortunately, people can still get pregnant in the perimenopause. You're not out of the woods fertility-wise until you're menopausal, although it's the chance of getting pregnant is really, really low, but it's still there. We're going to be discussing and bringing up genitourinary syndrome of the menopause, because it has been asked about enough in consultations. We're discussing your lifestyle to see whether we can just support ways of introducing lifestyle changes for you in the future, and we're discussing treatment options. So there's loads to discuss. So sometimes if you're going to your doctor talking about in the context of a menopause consultation, it's useful to book a double appointment because you can see how much there is to discuss. So often you'll need a 30-minute appointment to explore all those things, or a split consultation approach whereby you might discuss one thing in a 15-minute consult, and then you come back again later on and you discuss the next part in another 15-minute consultation. And it's useful to ask your doctor if they have whether they adopt a split consult approach or whether they have a 30-minute menopause consult slot as well within their surgery. So when you come with a cancer diagnosis, there's certain uncertainties from a medical perspective and also from a patient perspective that we have to navigate. So the aims from a doctor perspective is still the same. We want to provide individualized care. We want to help you, we want to help you manage your symptoms, we want to help you manage your long-term health, and we want to be inclusive because, as Fiona said earlier on, for a long time, people with cancer, people that might have had medical comorbidities that would have prevented them from, let's say, having HRT, they didn't have anywhere to go in the past. So now I think we're being more inclusive, which is great. Because menopause, everybody's going to go through menopause, whether you can take HRT or whether you're not going to not have HRT, and there's lots of other treatment options that people can have. The uncertainties that we have sometimes if people have had a particular cancer diagnosis is that we don't have a huge body of evidence, or sometimes we have no evidence, looking at giving people, and this presentation isn't about HRT, and I'm not trying to make it about HRT, but I suppose the elephant in the room is probably that some people mightn't be able to take HRT, and that is still considered the most effective treatment of managing multiple menopausal symptoms. So often the question is, or it boils down to, how can we manage menopause if you can't have HRT, if you're having a difficult menopause? Or what do we do if someone is having a really difficult menopausal journey? We've tried everything, and the question is, can we give this person HRT? But there's no evidence, we've evidence-free zones, and we don't know what that risk profile is going to be like. So they're the difficulties, really, for a lot of people. So in terms of symptom management, this is the same for everybody, whether they've had a cancer diagnosis or whether they've not had a cancer diagnosis. To manage menopausal symptoms, lifestyle modification can be of help. Psychological therapies can really be of help. Complementary therapies can help. Women's health physiotherapy can really help. Non-hormonal oral medication can really help. And then HRT I haven't read because sometimes it's on the cards and sometimes it's not on the cards depending on your individual cancer diagnosis. So lifestyle modification, and it can be really, when you're looking at this and people are saying just do A, B, C, D, E, F, G and it'll all be fine. And I know myself, it can be really difficult to, look at these slides sometimes when you're having a difficult menopausal journey and say, look, I've tried some of these, or how can I introduce these changes when I'm actually feeling really bad in myself? And I completely acknowledge that. To implement, but it's still important because long-term health is dependent on lifestyle modification fundamentally and foremost. And it's about introducing changes over time. It takes, they think, about 11 weeks to implement a habit or to build a habit into your working week. So this isn't going to be instant, but it's about making little changes over time and tweaks and not being hard on yourself and taking kind of the long window approach to this. But not going into every single one. Alcohol is important. There are studies to show that we're drinking more than ever in Ireland as women. 11 units of standard drinks per week is considered the low risk range for women. Ideally spaced throughout the week, so not taken all in one go. And ideally we shouldn't be drinking more than two or three units a day. Increased alcohol intake is associated with every type of cancer and liver disease and increase in cardiovascular risk. So it's important to address that if that is an issue, and not to be afraid to bring it up, because I sometimes feel that people are afraid to bring it up with their doctors. The other thing I'm going to focus there is smoking, because again I think that there's a really good supports there for smokers now in terms of psychological therapies and pharmacological therapies, patches, oral medications. And I find that people, again, are kind of reluctant to bring it up with their doctors if they're smokers. We would like you to stop smoking if we can, because it is associated with increased risk of cardiovascular disease, cancer, lung disease. So don't be afraid to ask for help with that. paraphernalia, I'm going to just comment on up there and the kind of 9 o'clock position there. There's more and more lovely kind of menopause gadgets coming in the market. You've got your portable fans that you can get on Amazon. You've got lovely fans now. Fans are actually coming back into fashion, which I think is really good. With the femtech movement, there's going to be more and more little, I suppose, tech gadgets to improve menopause for women over the next 10, 20 years. So that's going to be an exciting space as well. Sleep hygiene, so leaving the apps out of the room, meditation, mindfulness, diet I'm not going to go even touch because Samantha's going to be covering that, and stress reduction. Now, I've often find anecdotally that I think people that have had a cancer diagnosis in the past are good at, this is generalization, I acknowledge that, but are good at kind of managing stress because they've had to adapt to changes. But sometimes it can be, you find yourself, if you're a couple of years out and you're back into the kind of rat race, sometimes those kind of stressful life stresses can creep back again. So it's just important to make sure that you're reducing your stress if possible, and that can be hard in modern life. Exercise, this is essential. Exercise is a drug. It really is. If I could prescribe it, I'd prescribe it to everybody. The WHO physical activity guidelines state that we should have at least 150 to 300 minutes a week of moderate intensity exercise, or 75 to 150 minutes a week of vigorous exercise, or an equivalent combination. And that's actually a lot of time, really, when you when at it. And when I was trying to kind of look into myself, what is vigorous and what is moderate? But moderate intensity is thought if you're building up a sweat, if your heart rate is increasing over what its baseline is, and that's considered moderate exercise. Vigorous then is getting into the scientific, really kind of science of 6 METs, which is a metabolic resting rate. But I'm not going to even go there. But if you're building up a sweat, that's what you need to be having moderate exercise. In terms of muscle strengthening exercise at moderate or greater intensity that involves all major muscle groups on at least 2 or more days of the week. So I'm telling people now, it's worthwhile investing in or engaging in a resistance training class or strength and conditioning class, because it's really important for your bone health and your muscle health as you go through menopause and after menopause as well. Weight-bearing exercise, so examples would be brisk walking, running, dancing, resistance trainings, weights, tennis. Really important for bone and muscle health. Cardiovascular exercise such as swimming, cycling, really good for overall well-being and for general health, but isn't weight-bearing. So sometimes people aren't aware of that fact in relation to your bone and your muscle health. Any form of aerobic exercise can potentially improve menopausal symptoms such as sleep and mood, and improve the sense of general well-being. And it can also improve insulin resistance and glycemic control, so it can reduce the incidence of prediabetes and developing diabetes in the future. So that's improving your long-term health. Brain health is also essential, and I'm not going to, this is from the IMS, the International Menopause Society. They had their white paper last year was on brain health, this year it's on cardiovascular health. I'm not going to read down that page there, but if you're not familiar with the IMS, it's a really, really brilliant website, and they have really good patient information leaflets. And their leaflet on brain health, I find it's a really good. I haven't come across a document as good as this, but I'm just going to go down to the bottom 3 points there, because the top ones, we're aware of them: exercise, modifying cardiovascular risk, all those things, diet. But I think sometimes when you're experiencing brain fog during perimenopause and menopause, I find there's 2 patterns. Sometimes it's exacerbated by having too much on the bridge. There's too much traffic on the bridge. There's just too much stress in general. So by reducing that traffic on the bridge, that can be helpful, and that'll involve looking at your overall life and trying to reduce some of those external stressors if possible. But sometimes people actually disengage. They disengage from social hobbies, from interacting with their peers, because they're afraid of how their brain fog or their cognitive symptoms might be perceived by other people. But actually, we should be pushing ourselves a little bit if you're falling into the second cohort, whereby you don't have a lot, if you're not falling into the group whereby you have too much stress, but if you're kind of pulling back a little bit, try not to do that if you can, because it actually improves your brain health to kind of keep your brain active and keep it engaged. And we're all in the same boat here. The majority of women, I think, will have experienced some cognitive symptom with perimenopause and menopause. So you're amongst your peers. Psychological therapies, there's a definite evidence base for this, okay, across the board, to help with mood symptoms, VMS, which is vasomotor symptoms, hot flushes, night sweats, poor sleep, physical symptoms, and the acceptance of a difficult menopause transition or menopause. And it works, like I was saying. NICE have shown this in their menopause guideline from 2015. The evidence shows that it does work, but it's not a quick fix, and people have to persevere with it. Therapies can include cognitive behavioural therapy, and that could be self-directed via online tools, via apps, or via a trained therapist. And you can have targeted CBT now for sleep called CBTI, CBT for insomnia, which studies have shown is just as effective, if not more effective, than HRT for sleep. So that's really, that's a good take-home message to take aboard. Mindfulness as well, and coaching. So some people like menopause. Menopause coaches are they're increasing. There's a lot of them there now, and some people really benefit from the coaching aspect of kind of one-to-one sessions and group sessions, especially in terms of implementing changes in their life and changing habits and things like that. So that's also, I think, a good thing over the last couple of years. The Women's Health Concern, I don't know if you're familiar with their website in the UK, they have excellent little information leaflets on different aspects of menopause, but they have a very good patient information leaflet on CBT, and that explains the concept of CBT really well. And at the bottom part of that information leaflet, they go into more resources as well if you wanted to look at that in more detail. Complementary and alternative therapies. There's a growing evidence base for acupuncture for breast cancer survivors. And that has been shown to help with some of the muscle symptoms and aches and pains that people can experience, poor sleep, mood, and sometimes hot flushes and night sweats. There will be an individual response to acupuncture. Some people will find it a benefit and other people won't. But there is a growing evidence base for it in terms of people that would have had a cancer diagnosis in the past. There's a small evidence base for hypnotherapy, and that's in the North American Menopause Society guidelines. And individual therapies, I haven't mentioned them here, aromatherapy, different types of therapies, and I'm sure people in the room will have had benefit from some of these therapies, and although they don't reach the bar of, let's say, of a medical evidence, of evidence, because it can be hard to get that from in medicine, and doctors, medics are very snobby in terms of trying to reach the top bar of evidence, which is important. But some people will find individual benefits from some of the complementary therapies that if it works for you, then that it works for you, and that's a good thing. So I'm going to spend a little time talking about non-hormonal oral therapies, and these are important and have a role, especially for people that can't take HRT or who it's advised not to take HRT, because they can still work. And what they are prescribed medications that have been used in the past for other reasons, such as antidepressant, anti-anxiety medications, urinary incontinence, mood stabilizers, and epilepsy. So they were used for some of these conditions, but what people observed was that they were improving menopausal symptoms such as hot flushes and night sweats. So how these medications work is by a neurotransmitter effect in the brain. And we know that neurotransmitters are important in the development of hot flushes and night sweats and in mood symptoms as well, and that estrogen acts as a neuromodulator in the brain in perimenopause all the time. So that neuromodulation kind of changes around perimenopause and menopause. So there will be an individual response to how people respond to some of these medications. And we tailor these medications according to the symptoms that you have. So for example, if you have hot flushes and night sweats and your mood is low, then we might try you with one of the antidepressants used in the context for menopausal symptoms. So we're not going to be using the high doses used for used for depression and anxiety, but using smaller doses for treating menopausal symptoms. And I think it's important to differentiate between that. If you have a lot of urinary symptoms like overactive bladder, your mood is okay, then we might start oxybutynin, which is shown to be quite effective for hot flushes and night sweats, and can also improve urge symptoms. If your sleep is affected, then we might try gabapentin or melatonin or some of the others. So we gauge the medication according to the symptoms that you're experiencing. Now, like every medication, there will be side effects, as there is with HRT. HRT has side effects as well. So sometimes the side effects will limit the use of these medications. So we won't know how you're going to get on until you try them. But if one option doesn't work, often a second and a third option will. So they still have a really valuable role in treating menopausal symptoms. And like I said, we think it's a neurotransmitter effect. And down the line, it's been licensed by the FDA in the USA. It's in the final stage of trials here in Ireland and Europe at the moment. You've got neurokinin 3 receptor antagonists. So neurokinin 3, it's a mouthful, is a little chemical involved, we think is involved in the pathway of hot flushes and night sweats, a thermoregulation in the brain. So we think by inhibiting and targeting this little chemical, that it will improve hot flushes and night sweats for women. And so far, to date, the results from the trials have been really good with minimal side effects. So that's another medication that's probably going to be coming into our toolbox over the next year or two, and that's exciting as well. So I like this slide because I think it's a good visual of Francois, who did the study back in 2021. He looked at all the different non-hormonal approaches to managing side effects for people that are using adjuvant therapies after breast cancer. And you can see here, I don't know if is there a light here? I don't have light, but see here CBT, look how the 3 marks would be the most effective. So across the board, CBT has been shown to be effective for hot flushes, sexual dysfunction, weight gain, musculoskeletal and fatigue. So that's the only one that seems to get across the board results. That's very powerful. Exercise, where's my exercise? Board there. You can see there, weight gain, musculoskeletal symptoms, so the arthralgia associated with some of the adjuvant therapies, and fatigue. Exercise is shown to be very, very effective for that. The SSRIs, they're the non-hormonal medications that I've just discussed, very effective for some people for hot flushes, and sometimes for musculoskeletal symptoms. Acupuncture, possible role in hot flushes, the arthralgia, aches and pains, and fatigue. But there's a lot of different therapies here, and by utilising some of these, we'll hopefully try and get something that's going to work for you, and that's what we call multimodal treatment. So just a quick word about genitourinary syndrome of the menopause. The first line option for everybody that's going through menopause, we need to moisturise our vagina. Just like our face, we need to be moisturising our vagina. And there's lots of different products on the market that you can be using for that, which I'll discuss at the end of this slide. So usually the vaginal moisturiser will be twice a week or 3 times a week dosage. You apply it every couple of days. Especially as well if you're getting a lot of dryness, the emollient washes like Epiderm and Dipper Base, Double Base, you can also use them in the shower as well. So that would be kind of first line for everybody. Vaginal estrogen is a second line option for people after hormone-sensitive cancers that don't respond to vaginal moisturisers and lubricants alone. And there'll be a significant amount of people, and likely in this room, that don't get resolution of their symptoms with vaginal moisturisers and lubricants. So vaginal estrogen can be used by people after breast cancer diagnosis, after hormone-sensitive cancer, okay? Because it acts locally in the vaginal tract. You can be a pessary, you can use a gel or a cream, and it acts locally, and the amount that goes into the bloodstream is negligible. There might be a tiny little bit of absorption in the first week or two if you have a very, very thin vagina, but the studies have shown that this is not evident after a couple of weeks. So there's a growing consensus now within all the guidelines. So the BMS are happy that it can be used second line. They still caution it with aromatase inhibitors, but the St. Gallen International Breast Conference that took place this year, the consensus viewpoint by the breast doctors was that you can use vaginal estrogen second line even after aromatase inhibitors. And it's also in the North American menopause guidelines. So I think, we shouldn't be, if you're not getting any symptom response from vaginal moisturisers and lubricants alone, vaginal estrogen can be used and is thought to be safe. Women's health physio could be excellent, especially for painful sex and for helping some of the muscle tone or improving, either reducing tone or improving tone, because the pelvic floor can change around the time of menopause, and they're brilliant. They're absolutely excellent. There's other treatments such as lidocaine gel for vaginismus, so if penetration is really, really painful despite the vaginal moisturizers and lubricants, a little bit of numbing gel can sometimes help with that. Vaginal DHEA, which is a precursor to testosterone and estrogen, that's licensed for breast cancer patients in North America. And ospemifene is a serum, which is an oral medication and tablet, which can be very pricey, difficult to source in Ireland, but it potentially has a role for people that don't want to insert things into the vagina. We don't have a huge body of evidence looking at it for women after breast cancer or hormone-sensitive cancer. A vaginal laser therapy, there was a systemic review there back last year which showed that it was looking at RCTs, or randomized controlled studies of laser therapy versus vaginal estrogen, and we don't have a huge amount of those studies out there, but some of the laser therapies seem to be as effective, but we don't have long-term data looking at that, but that can also be an option for people that can't take or that are maybe feel reluctant to take vaginal estrogen. And psychosexual counselling. Psychosexual counsellors are excellent for helping people through low libido, especially if pain on intercourse isn't the issue. And lifelong treatment is necessary for genital urinary syndrome of the menopause. It's not going to go away, unfortunately, so it's something that needs to be managed throughout our lifetime. The brands that that I suppose people report back to me that they're finding benefit from would be Yes, Silk, Multigyne, Regel, Replens, Alvin B, Epiderm Wash, Double Base Wash. But just, again, it's probably a little bit of trial and error, but it's just trying to find that one that's going to work for you the best. So I mentioned the word multimodal therapy because if HRT is taken out of the equation and you've got multiple symptoms that are affecting you, we want to try and maximize impact. We want to try and maximize all the different treatments to give you maximum impact. So this is a possibility of what this could look like, but that could include for you healthy diet, exercise, acupuncture, vaginal moisturizers plus or minus vaginal estrogen, prescribed non-hormonal therapy. It's the Sleepio app, which I didn't actually mention during CBT, but that's a CBT app which can deliver CBT for insomnia, and CBT, mindfulness coaching, yoga. So that's your multimodal treatment using different types of treatment. What about HRT? So this was based on a study in the Irish Journal of Medical Science by the brilliant team up in Dublin, Professor Brennan, in the gynecological oncology service up there, and the first writer was Fionn Donoghue. But they were looking at the literature to look at HRT after different cancer diagnoses. And there shouldn't be any issue with HRT with colorectal, vulval, vaginal, cervical hematological cancers. It's still not advised to use HRT first line for breast cancer. That includes the hormone and hormone sensitive and hormone negative cancers, and some of the ovarian cancers, so the low grade serous, because that's thought to have estrogen receptors, clear cell ovarian tumours, and sex cord stromal tumours because they're thought to be hormonally influenced. And then the may have group there on the left. It can be a little bit of a grey area for some of these cancers. Lung, we don't have a huge amount of data and there's conflicting reports. Melanoma and womb cancer for early stage treatment, HRT is thought to be safe. And ovarian cancer, high-grade serous endometrioid cancer, kind of a case-by-case basis. So I know there's probably people in the room that mightn't have had breast cancer, but I suppose I am picking breast cancer because it is the most common female cancer that women can get. And I'm sure you probably know more than me about breast cancer, people that have lived through this. But it's heterogeneous. Everybody will have a different type of breast cancer, just like everybody will have a different type of menopause. And when we are thinking about, I suppose, managing menopausal symptoms in someone that has tried the multimodal treatment, has really tried everything, and is still really, really struggling, the question is, are we going to give HRT or not? And what are the risks of giving HRT to an individual person? And that's a very case-by-case basis, depending on your individual cancer. And unfortunately, the grade and the staging and your individual cancer is going to play a huge part in that decision. So like a hormone-negative early LCIS, DCIS is a very different cancer to an aggressive, high-grade, hormone-sensitive breast cancer when we're trying to make those diagnoses. Understandably, I suppose. Like I discussed earlier, there are treatments that people have during breast cancer which can worsen menopausal symptoms and cause quite significant symptoms for some women. That would be tamoxifen, aromatase inhibitors, chemotherapy, and GnRH agonists for younger women. Symptoms usually persist for the duration of those adjuvant treatments, but they are at their most pronounced at the start. So we do think that they can improve a little bit as you adjust to them over time. The kind of common symptoms that people can experience are the GSM, the loss of libido, and poor sleep. All those symptoms can potentially be managed by the multimodal approach. So all the guidelines across the board, oncology guidelines, BMS menopause guidelines, North American menopause guidelines, International Menopause Society guidelines, all recommend non-hormonal treatments first line to treat menopausal symptoms because of the concern of the lack of evidence or the poor evidence or the studies that we have suggesting that there might be an increased risk of recurrence using HRT after breast cancer. I'll discuss that in the next slide, but that's why we do go for a non-hormonals first line. If people are really struggling during adjuvant therapy, there can be other ways to kind of manage that along with a multimodal treatment. Sometimes people benefit from a drug holiday. So for aromatase inhibitors, that's usually a 4-week break. For tamoxifen, that's usually a three-month break. Or you might switch from an aromatase inhibitor to tamoxifen, or you can switch between different types of aromatase inhibitors. But that would be a discussion with your oncologist as well, obviously. The BMS consensus statement on the management of estrogen deficiency symptoms, arthralgia, and menopause diagnosis in women treated for early breast cancer states that lifestyle measures and non-hormonal interventions should be first line, but if these are ineffective, systemic HRT or low-dose topical estrogen may be considered, but only after taking specialist advice. So we do give HRT to some people after breast cancer diagnosis that are really struggling despite the multimodal approach and despite optimizing lifestyle. It is a case-by-case discussion, and we do have evidence gaps, and your individual cancer will probably play a part in that discussion as well. The randomized control study that that people revert back to was the HABITS randomized control study, and that was stopped early due to an increased risk of recurrence of breast cancer. Around that time, there was another randomized control study called the Stockholm randomized control study, and that was stopped when HABITS was stopped because of the concern that taking HRT to breast cancer will cause a recurrence. When they looked back at that study afterwards, HRT wasn't associated with an increased risk of recurrence in that patient cohort, but it was associated with an increased risk of a contralateral new breast cancer in the opposite breast. So there's also differences between those two studies to the progesterone. So the HABIT study had a kind of had a different type of synthetic progesterone to the Stockholm randomized control study. So in summary, there's a lot that we don't know about HRT after breast cancer. We're presuming that the newer types of HRT are safer because observational studies suggest that we are, but we just don't have a lot of evidence looking at what that would be in someone after an early stage DCIS and LCIS. We have absence of evidence for that. And we're less concerned about hormone-negative cancers, but there have been reports, there has been a Scandinavian study, which looked back through about 500 cases of breast cancer and in hormone-negative cancers, and they had an increased risk of a new cancer developing in the opposite breast, which is hormone receptor positive. And there was also a risk of recurrence at 8%, which had switched to a hormone-sensitive positive cancer. So that's just one study. All the menopause guidelines mention that study. It's just one study, but I suppose it does kind of give people, we still need to reflect on it at the same time. So that's, I suppose, where we are with HRT after breast cancer. We just don't have a huge body of evidence, and that can cause that leaves us with a huge amount of uncertainty. There's probably people in the room that would have had an early menopause, possibly due to cancer diagnosis. Going through menopause early, unfortunately, increases your risk of cardiovascular disease, osteoporosis, cognitive symptoms, and Parkinson's disease compared to your peers of the same age. So if HRT isn't contraindicated by virtue of your cancer, HRT should be given until the average age of menopause, which is 50-51. And just, if someone has gone through an early menopause, that can be of huge psychological consequences for you from a fertility perspective, especially if your family wasn't complete. We don't have an individual. We direct people to the DAISY network in the UK for POI, which is a really good resource for Irish women. Actually, we really should have one by right of our own. But Catherine O'Keefe, she's the Irish link for the DAISY network, and she runs monthly support groups for women with POI, which people find really helpful. If you have an early menopause as well, I suppose it's important to say that there's still a chance there's still a 5% chance that you're of spontaneous conception. So if you don't want to get pregnant, conversely, then contraception should still be used. And donor oocyte IVF is an established option. And if you haven't had pelvic radiotherapy, your chances of success with donor oocyte IVF is the exact same as someone that hasn't had, it's the exact same as someone with their own eggs. And everyone that has had an early menopause and a POI should have a baseline DEXA scan. So I'm almost finished. I know I'm probably going over time. This is just a little photo of the Lee Clinic. That's where myself and Rachel are based now. And the Complex Menopause Clinic in CMH will be a weekly clinic. And we're very happy to see anyone in the room that feels that you would benefit from our service, especially anyone that might have had a hormone-sensitive cancer. And we usually have a collaborative approach with the other specialities whereby we would engage with your oncology team, your breast team, and your gynae oncology team. My final take-home messages are: everybody will have an individual menopause, okay? Don't compare yourself, but educate, prepare, and seek help. There's help there, so please reach out. Prep for your menopause consult, get that menopause checker, read up on some of the resources, go in prepared if you can, because that's going to maximise your time with your GP. Lifestyle matters, it really is essential for optimising long-term health. Non-hormonal therapies can still be effective, they really can, and multimodal treatment is what we aim for if HRT really isn't advised. And there's some evidence-based resources. Thank you.